Okay. Good morning, doctors and everyone. So I will be presenting a case of pancreatic mass. So my patient, Mr. T, 72 years old male, which was a retired army officer, presented with a chief complaint of generalized weakness and loss of appetite for 2 months, associated with yellow discolorations of his eyes for 1 week. My patient was apparently well until about 3 weeks ago when he noticed his urine become dark, which he attributed to drinking less water. His wife noticed a change in the color of his skin to light yellow, and he developed generalized itchiness, which had become troublesome, especially at night, that disturbed his sleep about 1 week ago. It was not relieved by medication. With time, the yellow discoloration deepened, and he noticed some bruising over his forearm, but denies of any history or trauma. He also noticed a weight discomfort in the lower epigastric region above his umbilicus, which was accompanied by easy satiety. He felt nauseated but no vomiting. He had lost about 6 kgs in the last 2 months, which he attributed to poor appetite and food intake. He also claimed that his stool had become pale lately. He complained of central abdominal discomfort, feeling full and bloated after food, but denied of having any severe abdominal pain. Otherwise, he denied of change in bowel habit, no constipation, diarrhea or blood in stools. His urine habit were also normal. So for systemic inquiry, for cardiovascular system, there is no palpitation, no chest pain. For respiratory system, no dyspnea, no apnea, no cough. For gastrointestinal, no abdominal pain, no vomiting, no change in bowel habit. Genital urinary system, no dysuria, no increase or decrease in frequency of menstruation. For central nervous system, no confusion or headache. And for musculoskeletal system, there's generalized weakness, but no muscle wasting, no myalgia, no joint pain. For past medical history and past surgical history, he is a known case of hypertension and diabetes for over 10 years and are on oral medication. He is also a known case of gastroesophageal reflux disease and duodenal ulcer for the last 2 years, and H. pylori test was positive. Otherwise, he denied of any history of asthma, blood diseases, and there is no significant surgical history in this patient. For previous treatment and drug history, patient was currently on oral medication for his hypertension and diabetes. Patient did OGDS 2 years ago and was treated appropriately by his physician for his GERD and duodenal ulcer. There is no drug allergy to any drug. For family history, there is no family history of similar disease. Patient claimed that his father died of colon when he was 68 years old, and his mother had breast cancer from which she died 20 years ago. He has 3 siblings, and 3 of them do not have any major medical illness other than diabetes. For personal and social history, patient claimed that he had been a heavy smoker but gave up 10 years ago. He consumed 2 bottles of wines per week for the last 5 years, and he is currently staying with his wife, who is also a diabetic. His 2 children are both married and well. He is a retired army officer and is not employed now. For dietary history, he takes a normal diet, including meat, fish, and vegetables, and fruits, but he has special liking for fried food and meat. So these are the questions given by doctor. Highlight the important symptoms in the patient history. There's 2 months of history of generalized weakness and loss of appetite with yellow discoloration of the eyes for 1 week, dark urine for 3 weeks, change in the color of skin to light yellow for 1 week and progressively deepen with time, general itchiness, bruising over his forearm but denied of any history of trauma, weight discomfort in the lower epigastric region above the umbilicus, which was accompanied by easy satiety. So nauseated but no vomiting, weight loss of 6 kg for the last 2 months, associated with loss of appetite. stool become pale, and central abdominal discomfort, feeling full and bloated after food. So the patient did not have any significant pain. What is the significance of this pain? So pancreatic carcinoma with retroperitoneal infiltration or perineural invasion usually present with upper abdominal and back pain. So the presence of any significant pain may indicate the carcinoma has metastasized. So the next question, is the weight loss significant? If so, what is its significance? The weight loss is significant, yes. And weight loss could indicate that the cause of this jaundice is malignant rather than a benign one. So from the history, what is the most likely diagnosis? I would give a provisional diagnosis of pancreatic carcinoma, most likely to be carcinoma of the head of pancreas. And also like to provide a few differential diagnoses of cholangiocarcinoma, ascending cholangitis, hepatocellular carcinoma, and hepatitis. So moving on to the examination. As you all can see, this is the look of the patient. So on general examination, patient is alert and conscious, oriented to time, place, and person. Patient appears to be cachetic and unwell, slightly dehydrated, thin and jaundiced, and also slightly pale. Patient was not in pain, and no breathlessness, cyanosis, or respiratory distress. His BP is 160/90 millimeter mercury, and the heart rate is 90 beats per minute, and the oxygen saturation is 95% of room air. For the examination of the hand, there's no finger clubbing, no pulmonary edema, no koilonychia, no leukonychia. Radial pulse is 90 beats per minute, regular rhythm, normal character, no radial delay or radiofemoral delay. The palm were pale and yellow with scratch mark over his forearm and abdomen. The eyes there's icterus, but there's no paler conjunctiva. For the mouth, no central cyanosis, no oral stomatitis, and the oral hygiene is adequate. For the neck, there is no cervical lymphadenopathy. For the chest, there is no stigmata of chronic liver disease. There is no bilateral pitting edema, and cough impulse is absent. Moving on to the specific examination of the abdomen. On inspection, the abdomen is flat and no scar or other abnormalities seen in the umbilicus or other parts of the abdomen. No abnormal veins or pulsatile mass were visible. On palpation, abdominal examination revealed a firm liver edge 3 cm below the right costal margin, with the upper border of the liver at the 5th rib on percussion. The liver edge was smooth and firm but not tender. A tensely cystic mass which moved on respiration is probable in the right hypochondrium below the costal margin. It was not tender and globular in shape, smooth with no overlying skin changes. There was minimal tenderness above the umbilical region, but no guarding. Otherwise, there is no definite masses were probable in the other parts of the abdomen, especially in the epigastric and paraumbilical area. On percussion, the mass was down on percussion, and shifting downwards and fluid show were negative. Auscultation of the abdomen revealed the bowel sound was normal. Inguinal area are normal, and digital rectal examination is also normal. Examination of other relevant systems were clinically normal. So for the clinical summary, my patient, Mr. T, a 72-year-old male, a known case of diabetes mellitus, hypertension, GERD, and bacterial ulcer disease, presented with generalized weakness and loss of appetite for 2 months, associated with icterus, darkening of urine, jaundice, generalized itchiness, easy bruising, discomfort in the lower epigastric region and central abdomen, easy satiety, nauseated, loss of weight, loss of appetite, and pale colored stool. On general examination, patient appeared to be cachetic and unwell, jaundice and slightly pale. The palm appeared to be pale and there is sclera icterus. On specific examination of the abdomen, liver appeared to be enlarged and there is a cystic mass which moved on respiration, probable in the right hypochondrium below the costal margin. and there is minimal tenderness above the umbilical region, but no guarding. So the provisional diagnosis would be pancreatic carcinoma. Differential would be cholangiocarcinoma, hepatocellular carcinoma, and also liver abscess. Should I move on to investigation, doctor?
I think there's some questions, isn't it? No?
Question, yeah, correct.
Yeah.
Sorry. The question on examination, highlight the important parts on examination. A patient appeared to be cachetic and unwell, slightly dehydrated, thin and jaundice, and also slightly pale. The palm will also pale and yellow with scratch marks over his forearm and abdomen. And there is icterus. On specific examination of the abdomen, a firm liver edge 3 cm below the right costal margin with upper border of the liver at the fifth rib on percussion. Tensely cystic mass which move on respiration is palpable, and non-tender, globular in shape and smooth surface and down on percussion. And also a minimal tenderness above the umbilical region but no guarding. So where in the abdomen will you look for any masses in this patient and why? So look for masses in the right hypochondrium for any liver masses secondary to the metastasis, and also the umbilical area and para-umbilical area for any metastasis to the node, especially the system Mary-Joseph nodule. And what is the palpable globular mass in the right hypochondrium? It is the gallbladder. And is the liver enlarged? If so, what is the significance of it? The liver is enlarged and it is palpable 3 cm below the costal margin, and it indicates that the carcinoma has metastasized to the liver. So the clinical summary and provisional diagnosis I have given earlier.
Okay.
Yeah.
Okay. So what will be the clinical problem in this patient from the history and physical finding? Say in a few words, few lines, what do you think is the problem in this patient?
So patient have a painless, progressive and persistent jaundice.
Good, very good. Painless, progressive, persistent jaundice. All right. What else?
And darkening of urine with pale colors.
All that under jaundice. So it's obstructive jaundice.
Yeah.
Okay. What else? What else?
And there is a loss of weight and loss of appetite.
Okay. So what does this suggest?
Suggests is a malignancy, most probably.
So it's some malignancy. So now you come down some malignancy involved, which gives rise to obstructive jaundice, right?
Yes.
Okay, anything else?
And then
two more
there's
things.
also generalized itchiness and easy bruising.
Yeah, that all, but because of the jaundice, you can say. Okay, what else? So the problem is obstructive jaundice, painless, progressive, and also he has got this loss of weight, so we think it's a malignant cause. Okay, what are the other two important signs in this patient?
So on examination, the patient appeared to be cachetic and unwell.
Yeah, okay,
also indicate a malignant cause.
Okay.
And on palpation of the abdomen, there's a cystic mass which move on respiration, palpable in the right hypochondrium.
Just interpret what you think is the mass.
The mass is a gallbladder.
Just say enlarged gallbladder, enlarged liver. So these are the features. And liver also enlarged, isn't it? You say it's enlarged, isn't it? Okay,
Yes.
so liver enlarged, liver this thing. So obstructive jaundice, malignant problem, and then he is an old man, and then he has got this enlarged gallbladder and also enlarged liver. So how will you interpret this and come to a diagnosis? Pancreatic carcinoma, you say. Well, why you say it's pancreatic carcinoma?
Because first of all, the age suggested.
Okay, good.
Yes, and the symptoms also, which is the persistent, progressive, and painless jaundice.
Okay.
And there's also a palpable gallbladder.
Okay, so what does gallbladder palpable? What does it? What runs in your mind? This fellow got obstructive jaundice, got gallbladder enlarged. So what is some law that should run through your mind? What is that?
Yeah, the Coiser law.
So what does the law says and how is it applicable to this patient?
The law says that in a jaundice patient, a painless probable gallbladder is most likely not due to gallstone, but to other causes,
Okay.
like pancreatic carcinoma, head of
Okay.
pancreas.
Good. So that is important. You must mention. You no need to tell again cystic mass, removes all that. That you have to interpret what it is and say enlarged liver, enlarged gallbladder. Okay. So the mass is gallbladder. So then this Coiser's law says if the gallbladder is enlarged, the most common cause is gallstone obstruction, causing jaundice. So that is unlikely. So that means most probably it must be a malignant lesion. And most common among this malignant lesion is carcinoma head of pancreas. Okay, Chooi?
Yes.
Okay, so you no need to keep, when they ask you why, what are the important points in this one, no need to keep on saying specific examination, general examination, all that. He said, elderly man, 2 months loss of weight and appetite, progressive jaundice, painless, and then he's got a liver enlarged, gallbladder enlarged. Okay, you say the liver enlarged is due to secondaries. What other cause you think can be possible in this patient?
It could be, for example, hepatocellular carcinoma.
Yeah, I agree with you, but I always tell you, when you get a provisional diagnosis, all the symptoms and signs, try to tie to that. Don't put a separate diagnosis. Tie all the signs and symptoms to this primary diagnosis that you have made. So in a pancreatic carcinoma of the head of the pancreas, why do you get a enlarged liver? Of course, can be secondaries, which you said, I agree. Anything else?
I'm not sure, doctor.
Anybody?
Doctor, can it be biliary tree obstruction?
Yes, biliary tree obstruction. It is cannot be. Now there is biliary tree obstruction. So why the liver becomes enlarged?
The bile cannot pass through due to the obstruction.
So why liver get enlarged?
Not really sure that.
So liver becomes congested. Bile cannot drain, means it becomes congested. So always you tell the one reason, and then I have to ask you again to tell you the right reason. So actually it is due to congestion of the liver. So the bile becomes congested in the liver, so the liver enlarges. Okay, so that is the most common cause in obstructive jaundice. Of course, it can be due to secondaries. Okay, if it is secondaries, Chooi?
Yes.
How, when you feel the liver, how will the liver feel like?
You can feel nodules over the liver edge.
Good. You can feel 3 centimeters of the liver down below the costal margin. So how will the liver feel like if it is secondaries? One is nodular. Anything else?
It will be hard in consistency.
Good. Hard. What else? One more.
It will be tender.
Liver, usually carcinoma, not tender. Okay, painless. That's why it is painless. Okay, so normally carcinoma, it is already going on for 2 months. So the stretching of the liver is very slow. So they won't have any pain. So non-tender. Okay, what else? One more. How will the age of the liver feel like?
Irregular.
Irregular and blunt, not sharp. Okay, compared to, if you say if it is a liver abscess, it will be very tender. If it is hepatitis, also will be very tender. So the important thing in differentiate is hard, maybe nodular, and the age inferior, lower border of the age will be very blunt. Normally it is very shaped, very sharp. Okay, so you cannot feel the edges of the liver head. It will be very blunt. Okay, because there's a liver secondary set, it causes enlargement. Okay, any questions, anybody? Want to ask anything about this? So your clinical diagnosis will be pancreatic carcinoma head of pancreas. Okay, that is the differential provisional diagnosis. All the others can be liver abscess, hepatocellular carcinoma, cholangiocarcinoma, paraampullary tumors. These are all possibilities. Okay. Any other questions? Okay. Otherwise, we go to continue with the investigation. So with this diagnosis, provisional diagnosis in your mind, then you go to the investigation. All right.
So for investigation, first I will start off with full blood count to see whether there's any anemia or leukocytosis. And as the patient is a diabetic patient, I would like to do a random blood glucose. And then I would like to perform a liver function test, which may reveal a cholestatic pattern, which is an increase in serum bilirubin and ALP. And then I would like to do a renal function test and blood urea and serum electrolyte to monitor the patient fitness for surgery. And then I would like to do a tumor marker, which is CA and CA 19.9. And then I would like to perform also a chest X-ray to see whether there's any metastasis to the lung, and also to assess the fitness of surgery for the patient.
Okay.
Then ultrasound abdomen. I would like to find if there is any dilated bile duct or any mass in the head of pancreas. And also like to perform a contrast enhanced CT scan to locate the tumor and assess its resectability for the tumor. Okay. If the CT scan couldn't yield a clear picture, we can do further tests like ERCP, MRI or MR angiography, and endoscopic ultrasound. Yeah, that's all.
So let's say, okay, the blood test and all that, okay, good. Okay, in imaging, what will you do first?
Ultrasound abdomen.
Followed
by contrast enhanced CT scan.
Okay, these are the two things that you must do. So in this case, you want to do a chest X-ray, good, ultrasound and CT scan. So all the cases, pancreatic mass, abdominal masses, these are the two things that you must do first. Ultrasound, any mass in the abdomen, doesn't matter, pancreas, liver, whatever it is, first you do ultrasound. Why? Because it is no radiation and non-invasive, and it's easily available. Three things. Okay, non-invasive, no radiation, and availability is easily available. So you want to do a ultrasound, abdominal masses. Second one should be CT scan, either contrast or without contrast. Okay, so normally we'll do contrast enhanced CT scan because we do the staging at the same time. If you're thinking of CA, you want to do a contrast enhanced. Okay, then the other things will be ERCP, MRCP, and EUS. This, if necessary, then you want to do this. Okay, ERCP you want to do, you can do it to diagnose as well as for therapy. Later we'll talk about it. So this is the order of your investigations. Okay, next one. What's your next part?
For the management. So the management of pancreatic carcinoma mainly divide into whether it is resectable or not. So for resectable disease, mainly stage 1 and stage 2, we can do surgical resection. We can perform various types of surgery. For example,
what is stage 1?
Stage 1 is the tumor is confined to the pancreas, less than 2 cm. And stage 2 being the tumor extend out of the border of pancreas, but do not involve any extraciliary axis or any superior mesenteric vein or artery.
So it is still within the pancreas. Okay, stage 1 to 2. So early stage resectable. Let's say this patient is resectable stage 1 or 2 lah. Okay. So what will you do?
Perform a Whipple pancreaticoduodenectomy.
Okay.
Pylorus preserving pancreaticoduodenectomy.
Okay.
And if the disease is involve the body or the tail of pancreas, I would do the total pancreatectomy.
Okay, let's say this tumor is confined to the head of the pancreas. So what do you do? Which will you choose?
Whipple procedure.
Okay, Whipples or the pyloric preserving, PPPD. So this will you go for Whipples. Okay, the others. So in this patient, let's say is confined to the head, stage 1 or 2. Okay, let's say less than stage 2. Okay, continue.
And also give some adjuvant chemotherapy, mainly 5-fluorouracil or gemcitabine. And for inoperable disease, locally advanced stage 3 or metastatic stage 4, we can provide palliative care. The most important is to relieve the obstructive jaundice. With surgery, we can do surgical biliary bypass or stent placement with ERCP or PTC. We can also do surgical gastroenterostomy or duodenal stent to relieve the duodenal obstruction due to the carcinoma. And for pain relief, we can provide analgesia or ciliate plexus block. And we can also consider chemotherapy in some cases. And we replace enzyme for steatoria. And also we can treat diabetes mellitus.
Okay, good.
If there's a newly onset diabetes mellitus.
Okay.
So the question of on management, the patient tumor is inoperable. What do you advise for palliative biliary drainage? So like I said earlier, stent placement, either plastic or mesh metal stent at ERCP or percutaneous transhepatic cholangiography, PTC. And also we can do surgical biliary bypass, choledochoenterostomy. So you decide on cholecystogenostomy. How will you prepare your patient for the operation under GA? So first of all, we have to take patient's informed consent for the surgery and other consent. Then I would like to do a baseline investigation like full blood count, random blood glucose, blood urea and serum electrolyte, clotting profile, liver function test, routine chest X-ray and ECG. And also we make sure patient have adequate hydration, and we send blood for GXM, GSH, and we also give prophylactic antibiotic. And also we make sure patient having a proper fasting guideline with no solid food up to 6 hours prior to surgery and clear fluid up to 2 hours before surgery. And in this patient, patient is a known case of GERD and bacterial ulcer disease. So we need to give prophylaxis for expiration pneumonia, like H2 blockers, PPI, or antacid, or metoclopramide. And as he's a diabetes patient, we continue all medication. We stop the medication for diabetes, and we control patient blood glucose level to be as near as normal. And also we stabilize the BP to near 106. He is also a hypertensive patient. So we stabilize the BP to near 160/90 millimeter mercury, but we allow oral medication for hypertension in the morning of the operation. So how will you manage this patient in the ward post-operatively? So for the post-operative pain management, we prescribe adequate analgesic, and we continue IV fluid until patient is able to tolerate oral fluid at around 35 to 40 milliliter per kg per day. And we monitor the patient vital signs like the pulse rate, the BP, respiratory rate, temperature, and urine input-output chart. And we also prevent deep vein thrombosis by allow ambulation as early as possible. We can also wear elastic stocking, apply pneumatic compression of the limb, and also we can give medically with low molecular weight heparin or warfarin. And also we look out for the complications of the surgery. So what is the special complication of the surgery on a deeply jaundiced patient? A patient with deeply jaundiced most likely to have post-operative acute olivuric renal failure. They also tends to have coagulopathy, infection, hypertension. gastrointestinal bleeding, and also for the people surgery, they are more prone to have anastomotic leakage, which then develop abdominal abscess. And that's all from me, doctor.
Okay, now the others are okay. I just want to comment on this managed in the ward. Okay, you listed the whole list taken from the book, you know. But what will you do for this patient? That's the important thing. For your exam, you must tell your particular patient. So this patient is a diabetic. Okay, you mentioned diabetic and all that. He's a hypertensive. So all that very good. And whether you want to give heparin or not for this patient. He's already
No.
having bleeding tendency now.
No.
So you wouldn't want to give. That's the important thing. So this case, you cannot give him early ambulation, yes, but you can't give him warfarin or low molecular weight heparin in this patient because he's already having coagulation problem. You have to do a PT and all that. So it's not, don't give routinely for this patient. Is he a high risk for DVT?
No. Yes,
No.
yes.
Why?
Yeah.
What is the high risk?
Patient having no, not high risk.
Actually, he doesn't have any high risk factors for DVT, so you no need to do all that. Only thing is, any surgery, you must ambulate early to prevent this thing. So you can say ambulate early, move the limbs post-operatively. Even stocking, I think not necessary. Okay, so you have to tailor your management to that particular this particular patient. No, you don't list out the whole thing, you know. Okay, the special the number 4 is the special complication of surgery patient. And this is what you must have, I want you to emphasize. You all must know all this. What are the special complication of surgery on a patient who's going for jaundice patient who's going for surgery? Okay, post-op renal failure is very important. They call it hepatorenal failure. Coagulopathy, that means patient can get bleeding tendency. Okay, due to the anticoagulants that is, because of the deep jaundice, you can have having. So how do you before what do you give to prevent these bleeding problems, Chooi?
Vitamin K.
Yes,
Injected.
you must have, all the patients on obstructive jaundice or jaundice, you must give vitamin K before operation, few days. As soon as they come, you must give, because that will reverse the coagulopathy, coagulation problem. Then infection, they easily get infected. Then hypotension, okay, that is due to that. Why do they get infection?
Because patient is a cancer patient, which tend to have lower.
Yes.
Yeah.
Okay, another thing that you mentioned here, which you didn't mention here, is nutrition. Jaundice patient, especially cancer jaundice, obstructive jaundice for 2 months, normally they will have malnutrition because the vitamins will not be absorbed and a lot of factors cannot be absorbed for the patient. So they will have malnutrition. So you must improve his nutrition. And other important factor is they have liver failure, some degree of liver failure. The albumin will be low, globulin will be low. So you must give them nutrition before the operation. This can be given to nasogastric tube. Okay, then you can give them albumin. You can give fresh frozen plasma or albumin through the drip. Okay, human albumin. So this is to boost the patient's nutritional status, so that the risk of complications will be very much less. So once they have low albumin, they will have wound breakdown. So you get post-op wound infection, wound breakdown. Okay, so all these things. So the important problems will be renal failure, bleeding problem, infection, wound breakdown. Okay, these are the important things. Then the anastomotic leakage and all that. Yes, it's not specifically for jaundice patient, for all the patients. Okay, abdominal abscess, every patient also can get that. So these are the 4 things that you must address: coagulation problem, nutrition, renal problem. Make sure they don't go into renal failure. Make sure he's well hydrated. And the third one is infection. And the 4th is your wound breakdown. These are the 4 important things you must mention. Okay, any question? Otherwise, you can take out this thing. I think very well. I think Chooi did presented very well, but as usual, I always give the comment that you all bring the whole textbook into the presenting thing, you know, okay? You must pick and choose which is relevant to your particular case. That's why you must, from the history and the physical finding, you must identify what is the problem in your patient. Another patient with the same problem, his problem will be different. If he may be obese, okay, he has a past history or she has a past history of DVT, then it's a different problem. Okay, so these are the important things that you have to look into. Okay, this is the summarize. This is how you get history here, history findings, physical finding here, and then Courvoisier's law. We come to this diagnosis. All right. Then you come to the next diagnosis, differential. Then you have said you do all these blood tests. We already mentioned blood investigation, ultrasound, and CT scan. Okay, this is the blood test, liver function test for the patient. Okay, so any comment on it?
There's a there's a increase in total bilirubin.
Okay, good.
Yeah, and there's an increase in ALP.
Okay. So actually, must mention this, conjugated bilirubin is very much higher than the unconjugated, isn't it?
Yeah.
Okay, conjugated bilirubin. Total bilirubin is high, and mainly it is the unconjugated, conjugated. It suggests it is
Obstructive jaundice.
obstructive jaundice. Okay. Then the enzymes, not really marked. It's a borderline, not really increased. All right. Maybe slightly increased. They're not really markedly increased. Especially the ALP, then ALP is very high, much highly raised. So this the important thing about why we show you this is exam also they can show you a result like that. You must interpret what that does it shows is a picture of obstructive jaundice. So it confirms your clinical suspicion. Very easy, to confirm obstructive jaundice, very easy. Picture, symptom sign, and LFT. Straight away you can confirm. So the impression from there you get is obstructive jaundice, and the liver function is satisfactory. Once the liver function is satisfactory, you can rule out a lot of liver disease, such as hepatitis, cirrhosis. All these, the liver function also will be badly affected. Okay?
Yes.
Okay, now we go to the, next you say you want to do the ultrasound. Okay, this is the ultrasound. What can you comment?
The gallbladder.
This ultrasound of the gallbladder.
Yeah.
So it is standard, Okay. So when they ask you to say, this is the ultrasound of gallbladder, what can you see? The standard gallbladder. Anything else you can comment on the gallbladder?
The wall appear to be thickened.
Okay.
The wall of the gallbladder.
All right. Anything else? One more thing. The most common cause of jaundice?
There's no gallstone.
No gallstone. That's the most important I want to see. Whether the gallbladder is distended, whether the wall is thickened, and whether there's gallstone. These are the three things you want to see on a gallbladder. Okay. So after this, you want to do CT scan, isn't it? Just now you say.
Yeah.
Okay. This is the CT scan. What do you see?
We can see there's a enlarged gallbladder. And then can see there's a mass over the pancreas.
Okay. Can you point it with your wrist or not?
Can.
Okay, point it. Which one is the mass?
Okay.
Okay,
this
good. Red one. Okay, all right.
Then this is the gallbladder, yeah.
Okay. The gallbladder already mentioned. This Y thing they mentioned here. All right. This is a vague mass, radio opaque mass, soft tissue mass in the region of the head of the pancreas. Okay. All right, with the distended gallbladder. So head of the pancreas got mass, distended gallbladder, Coesius law. You can correlate it like that. This is the part that we are showing. All right. This one is what do you think is this investigation is?
Endoscopic ultrasound.
Okay, endoscopic ultrasound. Okay, what does it show?
Yeah, there's
Okay,
a mass.
and, okay, there's a mass here. And this one is clearly shown here. On GDS, you see a mass in the second part of the duodenum. Then here, you can see there's a mass here. All right?
Yeah.
The gallbladder that is distended. This is the portal vein. So this is the mass. So the ultrasound and CT scan confirms or gives you a diagnosis of CA head of pancreas. This is the other one. Mass. This is a gallbladder sludge here. Then there's a mass in the pancreas here. Yes, there's a mass here. This is the pancreas. So there's a mass in the head of the pancreas. All right, this is the endoscopic ultrasound showing you the mass in the head of the pancreas, and this is the gallbladder. Okay, same thing. Okay, ERCP, I just put it up here just to make it complete. We may not necessarily, if you are quite confident in your diagnosis or CT scan, maybe we do not need an ERCP and MRCP at this stage. Okay, so these are ERCP films showing you this pancreatic duct, CVD. Okay, and both the ducts will be dilated, and they call it the double duct sign. I'll show you another one. This is there's some obstruction here. So you see one duct here, bile duct, the other one pancreatic duct. This is known as a double duct sign. Okay, here MRCP, CBD, pancreatic duct. So both the ducts becomes widened. The space between them becomes widened because of the tumor infiltration. So that's why they call it double duct sign. And here also. Okay, double duct sign. One here, one here. This thing has moved. Okay, this is known as the double duct sign. Okay, these are the results. Okay, now I'll give you the result of obstructive jaundice. Features of obstructive jaundice. The gallbladder is distended. There's no stone. There's suspicious mass in the pancreatic head. CT scan confirms the suspect mass to be in the head of the pancreas. Then MRCP is not done yet, and EUS also not done. So in these patients, you may want to do a biopsy. So how to do a biopsy? You're doing an endoscopic ultrasound. Okay, just now we saw the mass, so you can put a needle through the scope there, and then you can take an FNAC, and that will confirm whether the lesion is cancer or not. Okay, so the final diagnosis, CA head of pancreas, and the most common one is adenocarcinoma. Okay, so this is the staging. I just put it up for you, which Chooi has already mentioned this. Okay, T1, T2 within the pancreas. Then T3 is outside. Okay, can go into the spleen, can go into the duodenum, can go here, kidney hilum, or the superior mesenteric artery. Okay, here. Okay, management, which Chooi said, resectable or not resectable. Resectable, curative. Only 15% of patients, when they come to you, they have resectable cancer. For them, like this patient who comes to us, stage 1 or stage 2, we do a curative surgery. And the curative surgery is pylorus preserving pancreatoduodenectomy with local lymphadenectomy or Whipple's operation. Most common popular operation is Whipple's operation, which I'll show you some diagrams how it is done. For tumor of the body and tail of the pancreas, you may have to do a distal pancreatectomy. Okay, so you have, first of all, you decide whether it is operable or not operable by your staging of the by CT scan and endoscopy. So if it is operable, you do a Whipple's operation or pylorus preserving operation. If it is inoperable, then you go for palliative biliary drainage. Endoscopy, you can do ERCP, biliary stenting, drainage and stent. Okay, so this is where ERCP comes in a patient with CA head of pancreas with jaundice. Or you can do surgery, do bypass, polycystogeginostomy or polydocoduodenostomy. So nowadays, with ERCP very advanced, we tend to go for this because it does not, patient is it's an advanced cancer. So you may be inoperable, so you are not fit for surgery, so you do this. Okay, this is the Whipple's operation where you remove the stomach, part of the stomach, antrum, the duodenum, whole of the duodenum, and also the pancreatic head, plus the gallbladder and the bile ducts. Okay, these are the things that you remove before, and after you remove, you join them back by a triple bypass. They call it triple bypass. Polydocoduodenostomy. Here, you use the jejunum to join them back. You do 3 anastomosis. Jejunum, you join to the bile duct, polydocojejunistomy. Join the transected part of the pancreas to the jejunum, known as the pancreaticojejunostomy. The third one, join the jejunum to the stomach. So there's a gastrojejunostomy. Okay, polydocojejunostomy, pancreaticojejunostomy, and gastrojejunostomy. So this is before the Whipple's operation. This is after the Whipple's operation. So this operation is also known as the Whipple's triple operation. 3 things to remove and 3 anastomosis to do. Okay. Okay, so this is the pylorus preserving operation, duodenectomy. So this is actually Whipple's, modified Whipple's. That means you leave the pylorus intact so that there's no reflux of the intestinal contents. Okay, that's the reason. So this you remove the stomach, you leave behind, you join it to the jejunum. So you get a duodenojejunostomy instead of a gastrojejunostomy. Okay, so this is the difference. Leaving the pylorus behind. That's called pylorus preserving pancreatectomy. Okay, this is the palliative ones I wanted to show you. Just the diagram is very explains by itself. This is percutaneous insertion of a stent A to the liver, going to one of the ducts are very dilated, so very easy to pass the stent. Then you put it into the bile duct. So once this stent goes there, they dilate, and then they drain the bile into the duodenum. B is known as the endoscopic drainage, where you do a ERCP and put a stent into the bile duct, and that will cause dilatation of the bile duct, and then the bile will drain into the duodenum. The third one is when the duodenum is obstructed. When the duodenum is obstructed, then you may have to put a stent into the duodenum, obstructed by tumor. So you get duodenal stent. So these are the 3 types of palliative procedures that can be done for these patients. It's very complicating. So just resectable tumors, only 15%, of Whipple's operation or PPPD. Okay. Advanced, we give chemotherapy for the adjuvant therapy is chemotherapy, and they use 5-fluorouracil or gemcitabine. Okay, so that is the surgical management for resectable. Unresectable, 85% of the patients, they come in unresectable. So you find out whether it's jaundice is the problem. Also, do they have duodenal obstruction or not? If duodenal obstruction is not there, which is not so common, then you don't have to do this thing. You only do stenting. The ERCP stenting is the treatment of choice. Okay, then you do the cholecystectomy, cholecystectomy, or cholecystectomy. And for palliative cases, then you may give chemotherapy, radiation, target, or immunotherapy. Okay, any questions or not? So all these we have already answered. What's the diagnosis, provisional diagnosis? Is already mentioned. Blood and investigations, these are the things. Just to summarize, how will you confirm the diagnosis? In this case, you have to do a biopsy by FNAC by EUS. Okay, EUS. You can do percutaneously, but percutaneous is not so accurate and is more dangerous. Outline the management of this patient, confirm the diagnosis, medical treatment, then staging, find out operable or not operable, then you decide on the operation. If it's inoperable, I already told you the procedures that you can do. Special problems of a patient with obstructive jaundice, we already discussed just now before we came to this, all right?
This is a video of a Whipple procedure on a patient with a tumor in the head of the pancreas. Metastases have not been detected and the tumor is considered resectable. The operation is initiated with an arced incision in the epigastrium. The abdomen is free of ascites or peritoneal metastases. The Coker maneuver is performed. The duodenum and the head of the pancreas are cut from the peritoneum. The duodenum can then be pulled over to the patient's left side, and the surgeon gains access to the vena cava and other retroperitoneal structures. Here we see the vena cava, the right renal vein, and the common bile duct. The hepatic artery and the start of the gastroduodenal artery are dissected. Rubber bands are placed around both arteries, the gastroduodenal and the hepatic artery. The portal vein is dissected by the upper edge of the pancreas. The greater omentum is opened to gain access to the omental bursa. The lower part of the pancreas is dissected. Here we see the pancreas and the stomach. The superior mesenteric vein is dissected by the lower edge of the pancreas. Here we see the vein. Blunt dissection is used to free the portal vein behind the pancreas. The surgeon palpates the pancreas and feels a tumor in the uncinate process. Everything is now ready to proceed with a resection. The gastroduodenal artery is cut at its departure from the hepatic artery. A rubber band is placed around the common bile duct. We can also see the band around the pancreas. The surgeon will now cut the small intestine. An opening for the surgical stapler is made in the mesentery. The small intestine is cut 8 to 10 centimeters distal to the ligament of Treitz using the GIA surgical stapler. This instrument places 2 double rows of staples and cuts the tissue between them in one operation. The stomach is next. This is cut by the angular notch with a larger version of GIA. The staple suture is then sutured into the intestine. The gallbladder is dissected from the liver. The cystic duct is cut and sutured. The gallbladder is removed. The surgeon can now divide the pancreas. He opens the serosa and cuts through the pancreas with a scalpel. The rubber band around the common bile duct is removed and the duct is cut. The tumor adheres to the lower part of the superior mesenteric vein in a small area. A little segment of the vessel wall is therefore included in the specimen. Here we see the surgical specimen with the duodenum, stomach, and the head of the pancreas. Here we see the head of the pancreas with a common bile duct, pancreatic duct, and a small part of the superior mesenteric vein. Here we see the surgical field after the resection. We see the remainder of the pancreas with a pancreatic duct, the common bile duct, the portal vein, the superior mesenteric vein with a closed defect, the vena cava, and the hepatic artery. The surgeon will now re-establish the continuity of the GI tract. The pancreas is anastomosed end to side on the small intestine, right below the closed end. The anastomosis is made with interrupted sutures.
So this is a pancreatico-jejunostomy, yeah? One of the
Here
bypass.
we see the finished anastomosis. The common bile duct is anastomosed end to side farther down the small intestine. The anastomosis is made with continuous sutures on the posterior side and interrupted sutures on the anterior side. Here we see the 2 anastomoses next to each other, bile duct and pancreas. A side-to-side gastroenterostomy is created using a GIA stapler. Here we see the suture with the stomach and the small intestine. The opening where the stapler was inserted is closed with continuous sutures.
This is a gastrojejunostomy, yeah? Third anastomosis.
The abdomen is washed and a drain is placed to the anastomoses. The abdominal wall is closed in 2 layers with continuous sutures. The skin is closed with staples.